Welcome. Hi. You're seeing my whole screen for a moment because of a little vagaries of my programs. But we're going to talk today about CFS viruses and tick-borne diseases. Now, this is an area that I have been interested for many years. I started off in the field of chronic fatigue back in the 80s and early 90s and continued with that until about 2001 when Wayne Anderson joined my practice, and I discovered that a lot of the people I was seeing with chronic neuropathic pain that was so atypical it didn't make any sense, actually had Lyme disease. And the rest is, as you all know, you start treating people, and actually a lot of them do get better. And I did note that some of the people, actually a fair number who I thought had chronic fatigue, actually did have some tick-borne illness underlying, and when we treat them, many of them would recover. Unfortunately, not all of them. And it was always a source of frustration for me, knowing who needed more therapy and who needed really different therapies. And this is something that I think you've all seen. A lot of chronic fatigue doctors really don't pay attention to the possibility that tick-borne diseases can be an issue. I'm going to talk more about that with some examples a little later on. But we also have the problem that many in the Lyme community don't recognize when they've done what they can treating the bugs, and we might have a different problem, and people often are left with chronic fatigue. So both of these approaches have not obviously served the patients as well as we'd like. Now, there are some newer concepts and tests that are helping us, well, in some ways, discern and dance with these question of which disease is active, or are any of them really the main driving force behind what's keeping the patient chronically ill. As always, the clinical signs and symptoms still are our best bet. We are still waiting for the perfect test, though I have noted of late that I think the ELISpot tests are helping us discern better between when infection is active and when it perhaps is just more persistent, especially with the tick-borne diseases. So the new and not so new concepts, the new concept is the cell danger response. Also, it's developed and popularized by Dr. Bob Navauix, and he's now really referring more towards more as the healing cycle, but it's the same process. We're going to go over this a bit in a minute. And I think the most important thing of the concept of the cell danger response is to remind us that chronic pathology is a function of the compensation of the body and not the direct result of the initiating trigger. And I think this is just crucial because I'll probably repeat this several times along the way, but chronic illness is the disease of the individual more than an expression of the initiating event. And I said, we'll come back to that concept. And the not so new concept is viral persistence and how it can be an element of CFS. And also we see it, I think, also mixing in with the tick-borne diseases, even in the midst of treatment. And this is something that I think many of us have been aware of and have tried to treat over the years. And I know for myself, I've gone in and out of this several times. But getting back to the cell danger response, we're going to just do a quick review of this. And that's basically the chronic disease develops when the normal healing cycle is interrupted, and you fail to finish the cycle. You get stuck in part of the pathway. One of the major concepts is the mitochondrial. The mitochondria is not just an energy producing machine, but also is constantly sensing the environment, modulating the cellular machinery, changing the DNA expression, and communicating that there is a problem in the cell to the rest of the body. Anytime the mitochondria senses a change in the environment, especially the energy and peptides that are being produced, it will change shape. It generally in healthy, I shouldn't say healthy. These mitochondria, I think this is the other important part. These mitochondria are not unhealthy. They are responding to stress in the body, and they change their function. We have gotten used to thinking them as dysfunctional because they're not doing what we would like them to be doing. But they're doing what they're supposed to be doing, which is protecting us. And we're going to try to make this a little clearer as we go on. But when mitochondria are working in the normal energy production pathways that we like our body to be using, they form filaments. They actually bind together in long chains. And when they get stressed, that filamentous nature breaks apart, and they form individual mitochondria that aren't necessarily touching each other anymore. Dr. Navauix refers this to the spaghetti and meatball forms. And those of us in Lyme, are well aware of how we see this in bacteria, how they change shape and form, and those different shapes and forms have different functions. The body is much more a shapeshifter than I think our conventional training ever led us to believe. Now, the other important part of the cell danger response, or one of the many important parts, is that ATP is not just an energy storage molecule, but it also is a cell signaling molecule. There are 19 different purinergic receptors that are found in the human body. And these are found on all different cells. Almost every cell in the body has some number of purinergic receptors which respond to ATP, UDP, AMP, ADP, adenosine, and several other purines. Now, when the level of ATP on the cell surface changes, that is a big signal for the system. When the change is small, you're just letting it can be just a chance to learn. In fact, our memory system works partially by this ATP signal, because when that's there, the dopamine and glutamate signals are amplified, and that's how come we can, that's why we learn when we're in danger. We tend to go through life without paying attention to everything that inputs, but when there's something that's a little bit rises to the level of awareness, it's usually because it can be dangerous, and the cell signal for that is an increase in ATP on the cell surface. Now, when there's a lot of ATP on the cell surface, we will have changes that are more than just local, and they can be systemic, and we put them under the rubric of illness behavior, as we see with just fatigue, social withdrawal, decreased appetite, malaise. These are all illness behavior, and you can find elements of this in single cell organisms using the same mechanisms of purinergic signaling. Now, you can read a lot more about this one in Bob's earlier articles about this is in Mitochondria in 2014. But basically, when ATP synthesis and nucleotide metabolism and associated signaling is disturbed, because basically the nucleotides, you stop making really long nucleotides that would be things that you would use as raw materials for growth, and they become much smaller. This sends a signal to the mitochondria. Now, as I said, inflammation is the body's normal response to danger, but it's a signal. You don't have to have something that's going to kill you. It can just be a hint of what's going on. Remember, the body's inflammatory response is meant to be transient. You know, it's how we heal. It's how we respond to everything. I mean, transient responses are what life is all about. Whether that be, you know, getting angry, getting frustrated, but when you're healthy, those things don't stay. And the same thing happens when a physical event happens. You know, you cut your finger, it heals, and within a few days, you know, there's no longer any inflammation there. It's on a further part of a much further along part of the healing cycle. The problem we get into is that when the healing cycle gets stuck, you wind up with chronic illness. Now, this very quickly. There's several slides here that I'm going to let you use as a reference. But just to understand the three steps, and again, these are probably not as clear cut as we think, and unfortunately, we really don't know yet how what the trigger is to get from one step to the next. What Dr. Navauix is laying out here is what he calls the healing cycle, but it's still a bit of a black box. And that's why we have so many different therapies that work for chronic illness, because different people need different help to encourage their system to move on to the next cycle. Now, the first stage of the CDR is, you know, with the acute injury, neutrophils are called in, there's lots of inflammation, and at that point, the mitochondria really do lower their ATP production for any use in the body. There's still some that's used just as a signaling, almost all as signaling on the cell surface. And the cell is using glycolysis for energy production predominantly. And the CDR2, this is when we're beginning to get proliferation, new cell growth, replacement of injured cells. This is also the same metabolism that you see in cancer cells, where we're really not burning fat. And this is something that I think about a lot when you have the patients who, you know, no matter how hard they work, they really can't get into ketosis, and even if, and more importantly, they feel miserable when they're trying to. I really think that a lot of these folks are stuck in CDR2, so their mitochondria are just not burning fat. Sometimes giving them preformed ketone bodies can help, because the brain can still use the ketone bodies. It's just that your mitochondria aren't producing them. Now, CDR3 is, at this point, your mitochondria are back to what Bob calls the M2 form, which is the normal anti-inflammatory form of the mitochondria. And they are using oxidative phosphorylation. Your whole electron chain is working all the way through. In the beginning, it's still working, but it is not producing ATP. You still are producing hydrogen ion concentrations, which are moving other functions and in the mitochondria, but you're not producing ATP, and you're not using up as much oxygen. In that CDR1, you're creating a very high oxidative state in the cytoplasm, because when you produce, just in step 4 and 5 is when you're of the electron transport chain, is when you're using oxygen. That's the sink, so to speak, the place where the oxygen gets converted to water. And if that's not happening, you'll get a pretty oxidative environment in the cytoplasm, which is a whole other lecture in itself. But if you're interested in this, you can look back to an old paper that Dr. Navauix wrote. I think it was called Oxidative Shielding versus Oxidative Stress. And I think it's a very interesting way of better understanding what we're trying to do when we use antioxidants. But just to continue with a quick overview of the CDR. So the natural progression of healing is to go through the steps, obviously. And the easy way to think about this is CDR1, just think of this in terms of our normal understanding of inflammation. So that's the hemostasis and inflammatory cycle. And the second part, CDR2, supports proliferation and the rebuilding. And CDR3 is when the cells are now beginning to have the cell receptors are working normally, the hormone receptors normally, and you're beginning to restore communication. And this is just important and remembering that this whole CDR thing can have effects systemic wide, but unless you're in sepsis, usually it's happening in localized areas of the body. Okay, and it can happen in pieces of the liver and pieces of the kidney, maybe simultaneously, maybe not. In the lung or the heart, depending on where the stress has been. But the important thing is so many of our patients are stuck in a piece of the CDR3 where they're losing cell-to-cell communication. It's not working as well. The hormones are not getting the responses that you would expect from the tissues. But this slide, this is really for your reference. It's much deeper than we want to get into today. And now as we're kind of tie this into the chronic fatigue world, in 2016, Dr. Navauix did this study. And as you can see, my clinic, Neil was there with us then, and Wayne and myself. We supplied the patients, I always say, and Dr. Navauix supplied the brains. But the reason I'm bringing this paper up today is what fascinated me and had me concerned when we were doing this paper is, I realized that my chronic fatigue practice had gotten a lot smaller in 2000, and actually we started collecting patients probably 2015 or early 2015, and I didn't have as many just straight chronic fatigue patients. But we look back and we had people that we were still seeing occasionally, and they had what looked like chronic fatigue. We had treated them most of the time in those days with antibiotics, usually a lot of IV antibiotics back then, and their joint pains went away, a lot of their neurologic symptoms went away. And they were better significantly, but they were left with chronic fatigue in the sense, and we're going to be going briefly over the definition of chronic fatigue, but as you'll see, my big definition of chronic fatigue is this post-exertional malaise, because I don't really see it in a lot of other illnesses that's this dramatic, where activity really produces a crash that can last 1, 2, 3, to a week, even longer, but often at least a day or two after exceeding that person's limits. And it can be from anything, physical exertion, emotional exertion, just cognitive exertion. And a lot of our patients have trouble with all these areas, but they can get exhausted. But when they start telling you they feel a lot worse the next day, they're getting into that chronic fatigue flavor in my mind. Now, as you can see, the thing that was interesting is that I said we had a fair number of people who that we used that had Lyme, but when we looked at their metabolites, and Bob looked at about almost 500 metabolites in these people, and they clustered pretty closely in order amongst females and males. I mean, there's significant differences in males and females that are much more than sex hormones, but the clustering of our patients was pretty tight and gave a nice signature. We can't call it a diagnostic test for chronic fatigue because we'd have to really do much more, but we felt this was an impressive sample, which pleased me greatly. Now, unfortunately, we did a second group about a year and a half, 2 years later, using the patients of a doctor who had been famous early in the 2000s for treating chronic fatigue. And I thought that we were going to get actually an even tighter group from his, because he just treated chronic fatigue. And I thought maybe my old Lyme patients might have skewed the data. And interestingly enough, it turned out that 2/3 of his women looked just like our women, but 1/3 looked more like the group that in people that Dr. Navauix felt had signs that looked like persistent infection, rather than just, I shouldn't say just, but rather than chronic fatigue and persistent, bacterial infection. Now, and that's what this plus some other interesting new findings that I'll get to is what kind of sparked my interest in giving this talk, because it brings up a really important point that I find frustrating, that many of the people who are working on similar patients to what we see, but the folks who decide that they have chronic fatigue, or the folks that decide they have mold, many of these doctors really don't believe that long-term treatment of Lyme or tick-borne disease is worthwhile. And I understand, because they see our failures. And, I speak to many of these people, and they are, reasonably concerned and upset when they see people who've been on IV antibiotics for a year or even longer and aren't any better, or oral antibiotics for that matter, and they're not any better, and they're often sicker than they were to start. And so they, don't really respect what we do, and for a good reason, because they see our failures. And I think the same thing happens with us. We see many people who have been to functional doctors who and naturopaths who just treated metabolically hormones and this and that, and fixed their guts, and they're still sick. And we see them and go, oh, it's obvious you have Bartonella, and we treat and they get better. So I just want all of us to pay more attention to the possibilities that are out there. And of course, that being said, the same thing with the mold treaters, who I think do a great job. But again, if somebody's not getting better after a year, we all should take, or 6 months, we should all take really good looks at what we're doing.